Hallo zusammen. So we're still at it in part 2. I put on the watch so you can see it is almost midnight and we're still filming. Okay, got the coffee and we're ready to go. This time we're going to be talking about lymphomas, and probably we're going to move on also with leukemias because lymphoma is going to be short. Okay? Yeah, and I got the basic one paper for the stuff that we did earlier. Okay, if you haven't seen that, go there. And that's it. Okay, let's get to it. Let's not make this video extra super long. So the topic now is gonna be lymphoma. Now, if you remember from what I said earlier about lymphoma, is that lymphoma is a tumor. Okay, it's a tumor of the lymphoreticular system. Okay, this is as a definition. Lymphoreticular system. Okay? Meaning the lymph nodes and the tonsils, so any lymphatic tissue, the GI, which has the, for example, in GI you have the myeloma, the mucosa associated lymphatic tumor, a myeloma, okay? For example, and liver and spleen, we know these, all of these are this system. So it's a tumor of these. And when these become overwhelmed with the lymphocytes, whether it's a B lymphocyte or a T lymphocyte, then this becomes a solid tumor. And this is now different than leukemia, which is, you can say, a liquid, or it's a bloody tumor, a tumor of the blood. So this is a solid tumor, which, when progresses, goes to blood. When progresses, becomes in blood. Okay? Difference from it. So what are the types of lymphomas? We have two major types. We have Hodgkin lymphoma and Non-hodgkin lymphoma. What is the difference? Okay. Now, Hodgkin lymphoma, whenever you say Hodgkin, okay, they are lymphomas, right? Remember, in lymphomas, you had two types of lymphocytes. You had the B lymphocytes and the T lymphocytes. The major types. You also have like others. So when you say Hodgkin, it is 100% a B cell tumor. So this is B cells, 100%. While if you say non-Hodgkin lymphoma, this is mainly a B cell. B cells are like 85%, it's a B cell. Okay? We'll write it here when we say the classification. So Hodgkin lymphoma, this one, we said it starts in the lymph node, then when it spreads, so here it becomes, here, starts from here, so this is now the tumor, it's larger and larger, okay? And then it goes to lymphatics, or to vessels, so then the second step, it spreads to lymphatics, and then from lymphatics, goes and spreads to other lymph nodes, to the neighboring lymph nodes. So you see this one has like a pattern, and then again to lymphatics and to lymph nodes. So this keeps spreading. For example, if this is the body, it starts from here and then goes down in a DMA, go down, okay? So it goes like this. It has a pattern, or it spreads regularly. Okay, so this one is regular, this one is localized. It doesn't disseminate throughout the blood everywhere. Okay, so this is regular and localized, of course, except if it becomes stage 4. You know, we have staging for lymphomas. So except stage 4, which is a really advanced stage, then you will have in it extranodal involvement. Extranodal involvement, all right? For example, as we said, the extra medullary. So the liver, lung, and bone marrow. So this is a general idea about it. Now, non-Hodgkin lymphoma, this is mostly generalized. Okay? Mostly. And unlike this, it has an irregular pattern. And because it's irregular, then you have involvement of these other areas. For example, Waldeyer's ring in the pharynx, or for example, in the skin, in the GI, in the brain. Okay, so it has this, and you can see if it spreads to all of these places, it's kind of worse. Okay, this is bad, people. Now, next thing that we're gonna compare these two with is how do we differentiate them from each other. Okay. Or what differentiates them other than this? In Hodgkin, the name of it comes from the cells, which are Hodgkin cells. So here you have Hodgkin cells, while here you don't. The cells involved in, or the cells that are the tumor cells, they are Hodgkin cells, and you have the Reed-Sternberg or Sternberg. So you have also RS cells, Reed-Sternberg. Now what makes these ones special is the Hodgkin cells, they have the CD, remember, cluster of differentiation, CD30 is positive in here, while the Reed-Sternberg is the CD30 positive and CD15 positive. Okay, so we can check for these cells and figure out if it's a lymphoma. This one, the non-Hodgkin, unlike this, so you don't have no Hodgkin cells, as we said, no Hodgkin, no RS cells, okay, no Reed-Sternberg, and no popcorn cells. Popcorn cells are also cells that can be found in Hodgkin, okay, but in some types of it. You'll see this one will have subtypes. Okay. What else? This one, the types of it, the types of cells involved in it actually depend on where the tumor originates. Remember here, if you have mantle lymphoma, by the way, all of these are non-Hodgkin lymphoma, all of them. So now we can add here, it's a non-Hodgkin lymphoma. So mantle are the mantle cells, okay? The follicular cells, and so on. So this one here, the types of cells found depends on where in the node it starts. Okay? And sometimes they can classify it according to the mutation responsible for it. Okay, so one of these two. Let's move on. Now let's talk about the classification. So the classification of Hodgkin, we said it's 100% B cells. Okay, now there are really different types of systems used. Okay, but the ones, so you can classify them according to histology. So you can see, you take in the microscope and you see that the centers of the lymph node, the center is nodular, sclerotic, or if it's lymphocyte predominant, lymphocyte rich, blah, 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 okay? Like these. And you can do it also by the immunomarkers. Now, by the immunomarkers, this one is the one found, maybe you'll find it in internal medicine in 6th year, and this one is mostly for pathology. Let's talk about this one because it is just a bit easier. It's not by how you see it. Okay, so you can have a CD30 positive cells, as we said here. So some types have the CD30 positive, or some tumors show a positivity in it, and some don't. But don't worry if they don't, because you can still find it from other markers. Okay, so the CD30 can be these ones, the one that we said, there's the nodular, there's the mixed cellularity. So they're basically the same names, but different how you group them together. So mixed cellularity, or lymphocyte depleted, lympho depleted, or lympho rich, and so on. Now the CD30, there's only, or they mostly make one type of histology, one type of a look, which is the nodular. So nodular lymphocyte predominant. Now if you ask me, why do the 30 negative make this type and these ones make this, it's just how it's found. I really don't know the answer. I don't know if if someone ever knows why these cells make this formation and the others don't. So anyway, here you will find the popcorn cells. Delicious. So the popcorn cells, okay? Rather than the Hodgkin and Reed-Stambag. What are they characteristic with or of? These ones. We know that they're definitely 30 negative, which is one clue. And the second is that they are CD20 positive and CD45 positive. Now the 20 is common for all B cells. Then you will find, oh, there's a B cell, it's 20, so it's a B cell that is not positive for 30, okay? And it also has 45, then we know for sure it's this type, okay, of Hodgkin lymphoma. So you take more than one clue, and it doesn't have to be always positivities that tell you an information. Being a 30 negative tells you this information. Because these are also B cells, and they can also show the 20 and the 45 here. All right, this is it. Now let's move on to the classification of the non-Hodgkin. So the classification here is according to the type of cells, because this one is 100% B cells, while this can be a T cell or can be a B cell. B cells are 85%. The majority are B cells. T cells are less, okay? Now the T cells can be anything. Maybe there is immature cells, or can be mature. It depends, for example, and you know where T cells mature, it's in the thymus, right? So you can have many types of the mature depending like where it happens or what. You can have adult type, you can have cutaneous type, You can have a disease called mycosis fungoides, or this Sézary syndrome. So they all depend on, these classifications can be according to how they look like, and they also have some differences between them. This is majorly a memorization process. I'm sorry, I cannot help much with these, because that's just how they are, that's how they were found. Okay, now let us move on to the B cells. B cells can also be like this, mature or immature, remember? Okay. But the one that I like more is, you say if it's indolent, meaning it's a sneaky one, or if it's aggressive. So if it develops slowly, there are types that develop slowly, and there are types that are very aggressive. And these ones have higher activity. The aggressive ones are really easy. Aggressive B will have a B in them. So B, Burkitt. So Burkitt lymphoma. And the other B is diffuse large B lymphoma. So you always have a B in the aggressive B type. Okay? DLBL and Burkitt. Now the indolent ones, you can have the small cell lymphoma, okay, SLL, if you don't want to write the M, okay, which we, as we said in the previous video, that they can overlap with the CLL. Or for example, the other types that we wrote, mantle or follicular, marginal. I made a way how to memorize all of these and to know them. So this one, the mnemonic for it is B. Okay. This one, aggressive B, is B. This one, I took the first two letters. There's a ma, and there's a fo, and there's a ma, and there's an S. Okay? And I'm like, mama, fos. Fos has no meaning, so don't try to overanalyze it. Okay, mama fos. I don't know, I just made up a word and now I know it's a word for me in my dictionary. Mama fos. Okay, marginal, mantle, follicular, and S for small. Okay, this is it about the lymphomas. So let's just take a preview as our friend requested. So we saw with lymphomas and the types, how to differentiate them, and at the end, the classification. Okay, the treatment for lymphomas is absolutely not bone marrow transplant, because the problem is not there. Okay, let me have a sip, and let's move on to the next one. So the next one is leukemia. Okay, so leukemia. Now when you say leukemia, and we know that the origin of it is from bone marrow, right? Then you need to know what are the types of cells found in the bone marrow, so you can know the blah 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 and the blah 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 blah. Okay, so one type we said is lymphoid. You have common lymphoid cells, common lymphoid progenitor cells, okay? Common lymphoid. And then, on the other hand, you have the common myeloid. Okay, lymphoid, as we said, will give you the B, the T, the NK, so forth. Now the myeloid, we will have a few diseases here. Okay, let me just talk about lymphoid. Lymphoid, in very, very general, we have, of course, we have to say the word, okay, the diseases that you get on this end, L and L, for leukemia. And it's a lympholeukemia. Either it's acute lymphoblastic leukemia or it's chronic lymphocytic leukemia. So from here, you get these two diseases, okay? ALL, CLL. Now on the myeloid side, you can have the following. So you might have a myelodysplasia, okay? Myelodysplastic syndrome, MDS for short. So it could be myelodysplastic, meaning the cells, instead of them growing to make something, they make something else, a dysplasia, okay? In Arabic, عسر تصنع. Or you can have just like ALL, you can have AML, acute myeloblastic leukemia, right? Or because the myeloids, if you remember from this here, we said the myeloid can give you myeloblasts. This is the acute myeloid, or erythroblasts and megakaryocytes. And if it's like a problem for these or for this, but a chronic one, now all of these will be in one entity, and it's called myeloproliferative because they proliferate. So myeloproliferative disorders. And when we say proliferative, these ones, they are what? Mature, okay? Unlike the AML. So this one can go further into these diseases that we know. So what if erythrocytes or erythroblasts are the ones affected? Then it will cause polycythemia vera, okay? Polycythemia vera meaning mostly there is increased red blood cells. Well, you'll see later that it's a secret. Also YPCs and platelets. It's a misleading name. So you can have polycythemia vera, or if the megakaryocytes, you'll have essential thrombocytosis. Maybe some books say thrombocythemia. Anyways, ET, right? Meaning increased platelets. Or if you have increased white blood cells, this is chronic myeloid leukemia. Okay? This is how to classify or to know which one's which, what is what, in very short. And now we will start with the diseases themselves. And the first one that we will mention is what? AML. So, or actually let's get rid of those, okay? Let's talk about ALL and CLL first and then get rid of them. So, first one is ALL. You see the word acute, then you know it's blasts. Okay, which blasts? For the lymphoid, common. The problem is common lymphoid progenitor cells. Blasts meaning they are immature. Okay, so you have immature lymphoblasts, whether it's a B or T, as we said. And the reason for this is a block due to a block of differentiation. Due to a block of differentiation. Okay? So, of course, if there's a process here, if there's a process like ting, 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 ting until here, and then it stops here, you don't have the mature cells, you have an overflow, an overspill of the immature ones. And of course, they are not as functional as the mature ones. So even though there's increase in the lymphos, the B lymphoblasts, but still it's not, you will still get infections, okay? As we said in the symptoms one here, okay? Because they will suppress the other bone marrow cells or blasts. Okay, so you still get infections even if it's a lot. So yeah, due to a block of differentiation. this is probably not in your lecture, but I'll just help you with it. There's a classification for ALL according to how mature or which phase of the B cells, for example, or the T cells. Remember here we said there's a pro-B and then there's a pre-B, okay? And these are still, both of them are blasts, and they're both ALL, okay? So the classification goes like this. You have L1, L for lymphoma, leukemia, lymphocytic leukemia, L1, L2, L3, okay? Although this is a little bit an old classification, but it's still okay-ish, okay? And this classification is, as I told you, according to the differentiation of the cells. Some cells will maybe, I think they look like they are undifferentiated. So they can be undifferentiated. Or if they are a bit more differentiated, then the nuclei will be irregular, okay? This is mostly helpful for 6th year students. Irregular nuclei. Well, if it's L3 here, if it's L3, then the nuclei will contain vacuoles in it, okay? All of this is a nuclei. I'll try to... Okay. Nuclei with vacuoles. So basically this is the classification of it. This is ALL. Same symptoms as we said in here. Okay, same therapy. And you can mention all of these things of what happens here, here about the leukemia. They overspill and invade and they suppress. There's extramedullary hematopoiesis, okay? That's why now we can go much faster. Next one, after ALL, CLL. What is it? So CLL usually happens for mature or a bit more mature cells, but not the blasts. And if it's for mature, then it mostly occurs with adults. Now, the adults, okay, as we said, we can have a T cells or a B cells, right? It can be either. The B are the naive cells, remember? These cells that are the last step of B cells in the bone marrow, and the same cells will come to a lymph node where they overlap. Okay, B naive cells. Or they can be memory cells, because there's memory cells. Remember these? Memory? We said that memory and plasma, they both go back to the bone marrow. Okay? So if in the bone marrow memory cells overgrow and proliferate, ta-da! Same problem. Okay, or memory cells. If you take a sample, so a blood sample of the periphery of a blood vessel, from a blood vessel, what would you see? You will see hypercellularity. So high cellularity. Why? Because they're mature. Okay? So, duh, like, you'll see a lot of abnormally mature lymphocytes. And that's it. What else? The SLL, just like a word about it, we said is a non-Hodgkin lymphoma when we explained about it in the nodes. Okay? And with this one, so basically CLL can develop a bit into SLL, okay? Because at later stages with this, you will find leukopenia. If the bone marrow is involved. What the heck is going on here now? So the problem started in the bone marrow. The bone marrow is overproducing B cells. So the bone marrow is hypercellular, okay? spilling it out to the blood. Blood is hypercellular. It goes to lymph nodes. Okay? You take a sample from lymph nodes, a lot of naive B cells. And then they circulate again here. They circulate again, and they come back to the bone marrow as invaders, not as the ones that are being produced from here. And when they invade the bone marrow, or you can even think about it that these cells from here will suppress, as we said, they suppress the others. In later stages, you will have hypocellularity, and then it will become SLL. Because at this point, it came as if it came from the lymph node to blood, to the bone marrow, okay? So they are intertwined, and they can have same. So we said, of course, leukopenia plus and anemia and thrombocytopenia, low thrombocytes, thrombos, okay? The thrombocytes can be also low due to the immune destruction, because there's too many, as we said, B cells that are not functioning properly. So the thrombocytes destruction can be immune mediated. Immune destruction. Okay? That's it, I think, about this one. Let us move on to AML. So one, now I'm saying number one because here, so of these ones. So one is AML, acute myeloid leukemia. On this side, what's increased? High blasts. Okay, my handwriting is gonna get really crappy right now because I will hurry up. The very important criteria for blasts to know that there are too many in the blood or in the bone marrow is that they are over 20%. Over 20% blasts, that is diagnostic for AML. Okay? And this is something that the doctor that I did my practice with, he was amazing, and he explained to me all these differences between them. It was very basic, just like I told you, and this is how I remembered it and told you now. So many thanks to him, Dr. Okay, I won't mention his name. Maybe he doesn't want his name mentioned. Dr. Barakat. So high blasts, more than 20%, that is diagnostic. That is very important in internal medicine. Okay? More than 20% blasts. And, of course, if they're blasts, they are not differentiated. Okay, they're not differentiated cells, meaning you will have the low RBCs, YBCs, and platelets. Okay? What else? The course. Now, AML has a course. Okay? It has a rapid and what? A gradual. Oh, duh, if there's a rapid, there has to be a gradual. Now, meaning that you can see when there is a rapid course and they're proliferating very fast, when you take a sample, you will see either the very end differentiated side of the equation or the very undifferentiated ones, okay? So you will see a very clear distinction between very not differentiated and the mature ones. And this is called a leukemic hiatus, okay? A hole, or hiatus leukemicus, if you want to say it in Latin. I know some professors prefer the Latin name. Okay, leukemic hiatus, meaning too many, let's say, pro-B, too many pro-B, and then there's none here, intermediate ones, and then there's too many B cells, or immature, naive B cells, let's say. Now, the gradual one is actually the one that develops from myelodysplastic syndrome. This one can develop into AML gradually. So the gradual is from myelodysplastic syndrome. Let me tell you a bit about the classification classification of AML. We mentioned in the ALL, we have L1 to L3. Okay, now in the AML, you'll have M0 or M1, sorry, M1 all the way to M7, also depending on the extent of differentiation of the cells. So the M1 is undifferentiated, meaning they're really blast, the common progenitor, maybe the very first cells, in the myeloblasts, okay? So this one is undifferentiated, undiff. I can tell you there's M2, M3, blah, blah, blah. The ones that are mostly important clinically. Okay, M2 is differentiated. Is it easy so far? First undifferentiated, then it differentiates a bit. The one that is really important is a 3. The 3, okay, tria, okay, this is a tria, or I don't know, is pro, okay, tria is pro. So this is a promyelocytic leukemia, and it's one of the important types of it. You can memorize furthermore 5 if you want. 5 is monoblasts. And M7 is the last one, that is the megakaryocytes. Sorry, megakaryblastic. That was my mistake. See, blastic. Because it's still AML, acute, and we said blasts. All of them are almost a blast or a step before. Let me just take this one here. Okay. Okay. Let's talk about this star right here. So, few words about the promyelocytic leukemia. Promyelocytic. It's acute. Promyelocytic leukemia. This one occurs due to a translocation. It's a T. Okay, do you remember which one was this? M3, right? This one is M3. Now, whenever, how I memorize it is you have 3. Okay, go 3, 5, 7. Okay, 3, 5, 7, 3, 5, 7. So the T, there's a 5 and there's a 7. And the mutation that occurs here is 15, 17. Okay? And this is one of the important translocations for you guys to know. What is this? Blah, 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 whatever. This one is responsible for the it's called a promyelocytic leukemia. This is the gene or the chromosome that occurs on it, this mutation. So promyelocytic leukemia. And this one here is RARA. So RARA is retinoic acid receptor alpha. Retinoic acid, remember this thing? It's the one found in vitamin A, or aka vitamin A. It is the same thing, it's not in it. Okay? And these, when this translocation occurs, it creates a new protein that's an oncoprotein. When we said how some tumors develop in here, in the how part, it can be translocation, it can be an oncoprotein. So you have an oncoprotein, which this, remember this thing, it means inhibit. So the oncoprotein inhibits what? Differentiation. So it inhibits differentiation, meaning there is, which leads to accumulation of promyelocytes. Very, very high promyelocytes. Okay? And by the way, one thing about these promyelocytes is that they cause another distinct problems other than the normal ones that you see in a leukemia, which are they cause two things. They cause clotting and they cause fibrinolysis. And that's why we mentioned it also, one of the reasons. So when you have too much clotting in the vessels and then too much fibrinolysis, what do we call this? DIC, disseminated intravascular coagulation. So you have DIC. What is the therapy at the end? Retinoic acid. And of course you can give other stuff that if you can block this mutation. All right, moving on. One was AML. Let's talk, oh, we already filled this paper. Next one, number 2, the myeloproliferative, MPS, or myeloproliferative syndrome or myeloproliferative diseases. Okay, we said these ones are not as extreme as the blastic phase. Okay, they're not, but still this one starts where? At a pluripotent progenitor cells. Okay, how will you see the bone marrow and how will you see the blood sample, the periphery? Say with me. Okay, did you guys guess it? Nice. So the bone marrow is hypercellular. Hypercellular, of course, because there is proliferation of these. It's a tumor that increases cells. It's a proliferative. So there's too many cells in the bone marrow. And the periphery, again, the same thing. Also hypercellular, same thing. Hypercellular. This one has a course. Okay, all myeloproliferative diseases have a course. They start chronically, they have a chronic phase, okay, that then develops into an advanced phase. Advanced. Okay? The chronic phase is where we have these diseases that are mentioned. By the way, this is 2, so I'm going to have 2A, 2B, 2C, 2D, which are the ones. The chronic one, as we said, where is it here? Myeloproliferative diseases are mature. Okay, so pluripotent. And we have these diseases. So these ones are in the chronic phase. So you can have PV, polycythemia vera, essential thrombocytosis, or CML. Now, when in the advanced stage, this one has actually 2, like this. It has 2 parts of it in the advanced. First, they start to accumulate and proliferate more and more, so it's an accelerated phase. And then it becomes full-blown crisis. A blast crisis, okay? The accelerated phase is just blasts are increasing more and more and more. What distincts, and then it develops to this one, blast. In the blast, what differentiates it from this one is, this is when you have the blasts become over 30%. See how much? Now, when we talked about AML, we said the blasts are over 20, okay? But this one, because they have been more and more and more and more, maybe they have been 15% blasts here, okay, or chronic, and then here they became 15%, so it's still not acute, but over time, they accumulate so much that they reach 30% blasts. That's way too much, man. Way too much. Okay? So, this is the MPS, and now we'll start mentioning the subtypes of it. Okay, A is CML, chronic myelocytic leukemia. So CML, what's the problem in here? We said there is too much abnormally mature cells. Okay, so much so that something very characteristic of CML is that the bone marrow becomes 100% cellular. And that's why they call it pus-like. Because it's full of cells. You know when you have an injury and then the cells, the white blood cells come in here, then there's pus. It's because of them. Imagine the bone marrow is 100% cellular. So it's all like celly, cellish. Okay? By the way, the normal range, normally it's 50%. So imagine. Okay? What are the characteristics of CML that are found in here? Okay, are we going to see the hiatus leukemicus? Is it there? Okay, let me use this. Okay, hiatus leukemicus, is it there? Yes. Okay, it will be there. What else? Periphery. Will you see increased white blood cells? You will. Of course, come on guys. We said too much abnormal mature cells. They will overflow, overspill. Not just very, by the way, it's very, very high white blood cells. I won't just put one, I'll put 3 arrows. So very high white blood cells. Which one? Mostly of them will be increased. Mostly, and for some reason, it's the Bezos. Not Jeff Bezos. No, the basophils. Okay? So mostly basophils, and to a less extent, eosinose. So yes and yes. Why do you... Okay, one way to connect it is that this is a chronic. So there's so much time for some cells to differentiate into basophils and eosinophils and so. Okay? We said that these are abnormal. Okay, let me tell you a trick about the word abnormal. Abnormal means they're not like normal. No, that's so magical, right? Now the normal cells have alkaline phosphatase enzyme, which is normal. So in here, the abnormal one, the alkaline phosphatase will be decreased, okay? Will be low. While here it will be normal. So this is one thing for us to differentiate a CML from something called a leukemoid reaction, okay? Let me just check something if we have mentioned this earlier. Okay, we haven't mentioned it earlier, but I will tell you about it now. Okay, in a sec. These white blood cells, okay, I said they are really, really too much. So much so that they will become, because remember 100% cellular, so they will overflow and they will all just go, not all, but a lot of them will go to the blood. So the white blood cells are too much that they will be over 50 times 10 to the power of 9 per liter. Remember the normal range? It was 4.5 to 11. 11 only, that's normal. And here it's 50. That's way too much, my friend. Way, way too much. Okay. Let me tell you a secret about CML. I'll make it in green and I'll make it starry night. Holy night, starry night. Okay, this star, okay, 90% of the CML is due to Philadelphia chromosome. Guys, this is a pass or fail Philadelphia chromosome. Okay, which is, as we said, translocation T922. What's the 9? What's the 22? The 9 is for the ABL. If you want to know ABL, it's Abelson or Abelson, I don't know. Abelson leukemia, ABL, okay? And this one is for BCR. What was BCR? Chain reaction, I think. Basic chain reaction, or I forgot. Anyways, it's BCR. Okay? And this leads to a hybrid protein. Okay? This protein has what? With tyrosine kinase activity. TK activity. Now, whenever you say TK activity, what does the tyrosine kinase does? It starts yalla proliferation. So they proliferate so much. Okay? Yalla proliferation. And not only that, but also, okay, not leads to, sorry, yalla proliferation plus they will inhibit the apoptosis. So it increases the cell, doesn't let them die, and increases their viability. I mean, this would have been good if they increase our muscles, then we'd be strong and increase our brain cells. But really, buddy, really, tyrosine kinase, you do this to us? Not only that, look what this... okay, we're fasting, let's not cuss. Not only that, but there is no cytokine response. So the cells will not die by the cytokines like interleukin 1 or 6 or, you know, the inflammatory ones that cause the cell to die. What's the therapy for it? We said bone marrow transplant, that's one thing. Or you can do tyrosine kinase inhibition. Do you notice that this T, and there is let me write it, inhibit, okay, inhibit. There's inhib, right? And this is where tinib comes from, okay, wow, my English. So you have like imatinib, the T for tyrosine kinase, and inhib, inhibition, okay? So whenever you see tinib, it means it's a tyrosine kinase inhibitor, but different, because tyrosine kinase is just an enzyme and it's there in different cells, so maybe they can target different cells. Or, for example, interferon alpha. What does interferon alpha do? We know it's a pro-inflammatory mediator, and it kills the Philadelphia positive cells. So that's a good one. It has been tried, and it's more effective to add it to the therapy, as I learned. Now, here I will start telling you about, it might be a bit short, but the CML versus the leukemoid reaction. Leukemoid reaction, okay? Versus this and this. I'll mention it in very short and explain it because it's there in the notes. You can read it more. We finished this, so let's... Here, that's it. Okay. What about the Philadelphia chromosome and the translocation of 922? Philadelphia. Of course, here it's positive and here it's positive. Okay? While here it's not. It's not. This is one thing. The next is the white blood cell over the red blood cell ratio. Or you can just keep it as white blood cells. Which one do you think will have more white blood cells? A tumor that produces white blood cells? Or just a reaction? By the way, leukemoid reaction is when you have an inflammation and then the body responds by making some white blood cells. Of course, here it's much higher than this, while here is just high. Okay? Next one. The maturation, for example. So when the body is in an inflammatory state and it's giving a signal for the bone marrow to produce more, well, it's not a tumor, so it will produce and they will be mature, okay, and functional. But here they are abnormally mature, right? Because it's a tumor and it is, as we said, partially immature. Are they functional then? Function. Well, here, well, it's hell no. So now, well, here it is. Part of the function is the alkaline phosphatase. There's no alkaline phosphatase, or maybe it's low because the cells are not fully, but here it's normal, okay? Or even high can be. What else? Splenomegaly, for example, splenomegaly. Well, in a tumor, cells are overproduced, they overflow, and then there's the extramedullary hematopoiesis, so splenomegaly is there, while here it's not. And last is the basophils, the basos. So the basos are really, really increased in here because, as we said, for some reason, these specific cells are now helpful to us as a marker or as a characteristic for it. Others, not. Okay, now let us move on to the next one. PV. Now this is number B. Polycythemia vera. Okay. Polycythemia vera, as we said, is a bit misleading name. Okay, because we have increase in the erythroids and the increase in the myeloid. Myeloid, and increase in the MEGs, the megakaryocytes. What is the cause of it? The gene responsible. Mostly, you can say 90% is a JAK2 mutation. Now this is another one that we are learning. JAK2 mutation, and when it's mutated, it will lead to the activation of the pathway JAK-STAT pathway. I think you only can know until here and stop. JAK-STAT path. But if you're a nerd like me, you can learn more. I'm not going to give you a headache with it. Okay. Not only that, this is one part of the problem, or one criteria. The other one is you should have also, for example, erythropoietin or thrombopoietin, TPO, or some kind of a mediator that will cause or initiate the expansion of these cells. For example, the colony stimulating factor, the G colony stimulating factor, GM colony stimulating factor. So these two together, when there is a mutation and something activates it, you'll have all the cells being produced more and more. The symptoms that we see, or if you check the bone marrow and the periphery, what will you find? Bone marrow is hypercellular. Periphery, same thing, there's high count. I just changed the name, but it's the same thing. High count for all of them, okay? RBCs, YBCs, blah, blah, blah. So increased RBCs are right here just because each one will give us different symptoms. So high RBCs, you will see the person having a lot of hematocrit, okay, HCT, and high viscosity. What else? And so HCT, viscosity, and the third one is because there's too much red blood cells, okay, and the human can take just as much as he can from oxygen, then the oxygen will be dispersed all over these too much cells, okay, and not all of these cells will have oxygen on them. So when you take a sample, you will see some cells without oxygen, meaning the hemoglobin is reduced or unoxidized. Reduced hemoglobin or unoxidized hemoglobin. Okay, So this is one thing. Increased white blood cells, meaning they will secrete histamine as a mediator, and this will cause the itching and the pruritus. Okay, too much histamine, itch. Too much platelets, here you have the thromboembolic and bleeding disorders. Because if there are too much, they will clot or they will coagulate, come together. And then if they're also too much, they will kind of hit each other and they break down and they cause the bleeding, degranulate and cause bleeding. So you'll have both of them. Okay? Therapy is phlebotomy. Okay? Moving on. E-T. That's number B. Now we are number C. So, ET, essential thrombocytosis. In here, since it's a type of a myeloproliferative disease, then the cause is also a JAK2 mutation. So we have the JAK2 mutation. This is the cause. Okay, but it's to a lesser extent. I mean, you can find it in 50 to 60% of the cases that you have a JAK2 mutation. Or it could be, or I'm gonna make it in orange, or it could be the MPL, myeloproliferative leukemia. So there's a certain gene which gets mutated when this one, or can cause essential thrombocytosis. Okay, so what does it lead to? As we said, there is excessive megakaryocytes. So there's megakaryocytes. So excessive megakaryocytes, but the red blood cells, the RBCs and the YBCs can be normal. Now why is that? Because as the lines go further and further, and okay, here. So as the cells develop, you can have this only. So you can reach a point where this one is abnormal and there's nothing wrong with these. So now the line is a bit more differentiated. So these are not affected. That's why they can be normal. Okay? Well, if it's up in the upper levels, then it affects everything after it. It's just a common sense. So red blood cells and YBCs can be normal or decreased in later stages. Okay, if they are suppressed, of course. All right, what are the symptoms for someone who has ET, meaning too many megakaryocytes? Remember when we said platelets, they are increased here in polycythemia vera. So too many platelets here, same thing, too many platelets, then you'll have thromboembolic accidents and or hemorrhage. Okay, now I'm gonna mention a few examples since this has not much to say about. For example, the thrombosis can occur where? In the coronaries, and then what do you expect? MIs. Yep. Infarctions. Or it can be in the brain. This causes stroke. Or it can be deep vein thrombosis. It could be in the hepatic vein. And this one in the hepatic vein causes what? Something called Budd-Chiari syndrome. Budd-Chiari syndrome. This is it. It's basically just hepatic vein thrombosis. So all of these are the examples. And the hemorrhage, as we said, same things. It could be gingival in the gums. Or anywhere else. Epistaxis, blah, blah, blah. Ecchymosis, petechia, so forth, so on. Okay, next one. After ET, we have the last one, which is, I didn't write it here. Okay, remember here we said these. Okay, I should have added one more because there are other types of cells. Now, these are the most, I'll make it dotted. These are the most common, red blood cells, platelets, white blood cells. But also you have fibroblasts, okay? So if you have fibroblasts, which are too many, then you end up with something called MF or PMF, myelofibrosis or primary myelofibrosis. So now let's talk about PMF. And this is gonna be number D. We said A, B, C, and this is D now. So in myelofibrosis, the reason, the cause of it is also same thing. Yep, you expected it. A JAK2 mutation. Or what? Okay, a JAK2 mutation or MPL. Okay? So what happens in here? There's too many abnormal, or let's change the word and call it deranged. Wow. Okay, deranged hematopoietic cells, meaning the bone marrow is going to be what? Hypercellular. Okay? What does it lead to? Too much fibrosis. Exactly, fibrosis. Okay, what is this fibrosis caused by? What do the fibroblasts secrete? TGF-beta, tissue growth factor, TGF-beta, or platelet-derived growth factor. So there are too many fibroblastic factors. Okay, what does it cause? Remember when we said too many cells of the white blood cells make it pus-like? Now in this one, it will be actually dry, because the bone marrow, which lies in a, let's say in a chamber, now will get fibrosed like this. Okay, you have fibrotic tissue inside it, and this will cause, when you try to aspirate, you will have a dry aspirate or dry bone marrow. Dry aspirate. Okay, meaning in later stages, later, 20 hours later, well, not 20 hours, no, I mean in later stages, then it will be hypocellular bone marrow. This is the stage of the failure. Okay, in failure stage. And at this stage, what happens? This will lead to, okay, so cells or bone marrow is not functioning. Where do we get our red blood cells and white blood cells from? We will get the extra medullary hematopoiesis. Okay? So splenomegaly, hepatomegaly, and all of these things. What's the therapy for people with PMF? Well, JAK2, what does it mean? Or MPL, there's a tyrosine kinase. So you can use a drug that ends with tinib. Something tinib, zumatinib, I think, or luxotinib, I think. Anyways, I forgot it. Tinib, which is a tyrosine kinase inhibitor. And this one has a different name than imatinib, the one that we talked about in CML, because as I told you, different tyrosine kinases exist in different cells, so you can target a specific cell for it. Okay? What else? Okay, so BM failure, as we said. So these will cause the same things of any leukemia, by the way. So just because we're saying it's a fibrosis, you would still see all of these, the anemia and low whites or mean infections, hemorrhage, and everything of a leukemia, okay? I know the name is different, fibrosis, but it's the same thing. Now, the very, very last thing I want to mention is, so we talked about myeloproliferative, okay? And these all can become AML. Oh, sorry, I put here, it's here. So all of these can become AML. Now, myelodysplastic syndrome also can become AML, but okay, gradually also. But I wanted to write it here. Sorry, that was a mistake. Okay, so here. So what is myelodysplastic syndrome? It's not discussed in our lectures in pathophysiology, Well, let me tell you about it. Basically, we said it means that there's a dysplasia. So that the stem cells, the progenitor cells, won't be able to differentiate. And that's different from the time when we say that if they differentiate abnormally, then you end up with... if they do not differentiate, then you have accumulation of the stuff before, right? And there's lack of the cells that come after, the mature cells. But if they differentiate abnormally, then there's a whole new line of cells that are abnormal, okay? And this is something that happens here. This has many, many subtypes, but the main characteristics that you see in here, dysplasia, are, you can call them weird looking cells in the bone marrow, and you will see still the anemia, the thrombocytopenia, and the leukopenia. So all of those will be there, and you have to differentiate them clinically. The way to diagnose it, it's not easy, really. This is one of the very difficult stuff in hematology, to know them. But you can aspirate, and there are some known genes to cause these problems. And you will see the weird looking cells from the bone marrow aspirate, and you can diagnose it. Okay? So this was it about the leukemias, lymphomas, and everything. I hope you find it beneficial. The stuff I didn't mention, you can read on your own, like the plasmacytic myeloma, something different than the multiple myeloma, and the MGUS, the minimally significant or unknown significance, monoclonal gammopathy of unknown significance. All of these are, so they're all really have minute differences from the diseases, but if you get the basic ones right, you can differentiate it. And the others are usually a pre-stage to the main diseases that we mentioned in here. Okay, it's already daytime. We've been filming and I've been spending so much time on this video. Let me know if you need anything else for us to discuss and do. Good luck, study well, VCS.